नमस्कार. महाराष्ट्र राज्य औषध व्यवसाय परिषदेच्या औषध माहिती केंद्राच्या वेबिनार भाग 15 मध्ये आपल्या सर्वांचं स्वागत आहे. आजचा टॉपिक आहे वर्ल्ड हेल्थ ऑर्गनायझेशन अँटीबायोटिक्स अवेअर, अ प्रॅक्टिकल गाईड फॉर कम्युनिटी फार्मासिस्ट. आणि आजचे आपले स्पीकर आहेत डॉक्टर भास्कर गवित्रे सर. Bhaskar Gavitre sir is a Ph.D. M.Pharm in Pharmacology with 15 years of experience in this field, and he is also an associate professor at Gahlot Institute of Pharmacy, Navi, Mumbai. A hearty welcome to you, sir, and over to you. I'm sure that participants will be excited today to learn a little bit about this antibiotic classification from you.
Very much, madam. I am taking this forward. Welcome all the fellow pharmacists and my friends. नमस्कार सर्वांना, सर्व मित्र आणि मैत्रिणी फार्मासिस्ट हो. आजचा आपला टॉपिक जो आहे वेबिनारचा तो आहे वर्ल्ड हेल्थ ऑर्गनायझेशन अवेअर क्लासिफिकेशन, practical guide for community pharmacists. So here you can see that AWaRe is written like capital A, capital W, small a, capital R and small e. The reason is here it is classified in a such a way that हे अशा पद्धतीने आपल्याला एक क्लासिफिकेशन दिलेलं आहे. The A that stands for the axis, WA that stands for the watch, and the RE that stands for the reason. तर आपण या आजच्या सेमिनारमध्ये काय शिकणार आहोत, तर कशा पद्धतीने अँटीबायोटिक्सला क्लासिफाय केलं गेलंय आणि याची गरज का आली आणि फार्मासिस्टचा याच्यामध्ये काय रोल आहे आणि हे किती इम्पॉर्टंट आहे, ह्या सर्व गोष्टी आज आपण या वेबिनारमध्ये शिकणार आहोत. तर हे जे आहेत ते आपले ऑब्जेक्टिव्ह आहेत वेबिनारचे. तर पहिला ऑब्जेक्टिव्ह आपला आहे अंडरस्टँड द अँटीमायक्रोबियल रेजिस्टन्स बर्डन. ही मायक्रो ऑर्गॅनिझम जे असतात अँटीबायोटिकला कशा पद्धतीने रेजिस्टन्स डेव्हलप करतात आणि सध्याचं स्टेटस, इफ वी आर कन्सिडरिंग द वर्ल्ड सिनेरिओ, तर सध्याचा अँटीमायक्रोबियल रेजिस्टन्सचा रोल किती आहे आणि भविष्यामध्ये त्याचं काय होऊ शकतं आणि आपल्याला कशा पद्धतीने तयारी केली पाहिजे ते आपण अंडरस्टँड द AMR बर्डनमध्ये बघणार आहोत. नेक्स्ट आहे लर्न द अवेअर कॅटेगरीज. आपल्याला याच्यानंतर क्लासिफिकेशन जे WHO ने दिलं आहे ते कुठल्या बेसिसवर दिलं आहे आणि त्याची जी काही थेरॉटिकल पार्ट आहे तो आपल्याला बघायचा आहे की क्लासिफाय कसं केलं. नेक्स्ट आहे अप्लाय द अवेअर इन द डिस्पेन्सिंग. जो थेरॉटिकल पार्ट आपण शिकलो आहोत ॲज पर द क्लासिफिकेशन गिवन बाय द WHO, हाऊ वी आर इम्प्लिमेंट, तो आपण आपल्या डेलीच्या रुटीन प्रॅक्टिसमध्ये, आपल्या रिटेल फार्मसीमध्ये आपण ड्रग डिस्पेन्सिंग करताना सोप्या पद्धतीने आपण कसं वापरू शकतो हे आपण इथे शिकणार आहोत. आणि लास्ट आहे आपलं इम्प्रूव्ह द पेशंट काउन्सिलिंग. सो हियर द पेशंट काउन्सिलिंग प्लेज द इम्पॉर्टंट रोल वेन वी ट्राय टू मीट these objectives, especially reducing the resistance developed by the microbes to the antibiotics. So patient counseling हा एक खूप मोठा मुद्दा आहे जेव्हा आपण असं कन्सिडर करतो की अँटीमायक्रोबियल रेजिस्टन्स जो आहे तो आपल्याला आता कमी करायचा आहे. ठीक आहे, सो आपण सुरू करूया. तो सर्वांना माहीत आहे की अँटीबायोटिक्स काय आहे आणि अँटीबायोटिकची हिस्ट्री सर्व लोकांनी स्टडी केलीच असणार आहे. मी जस्ट गो थ्रू तुम्हाला एक सांगतो स्टोरी, हिस्ट्री फक्त शॉर्टमध्ये, की अँटीबायोटिक्स हे असे केमिकल सबस्टन्सेस असतात जे मायक्रो ऑर्गॅनिझम पासूनच आपल्याला मिळत असतात आणि ते दुसऱ्या मायक्रो ऑर्गॅनिझमच्या अगेन्स्टमध्ये जे आहे ते इफेक्टिव्ह असतात. ते कशा पद्धतीने इफेक्टिव्ह असतात, तर ते दुसऱ्या मायक्रो ऑर्गॅनिझमची ग्रोथ थांबवतात, त्याची वाढ थांबवतात किंवा त्याला किल करतात. They destroy the other microorganism or they inhibit the growth of the other microorganisms if we are using these antibiotic in a small concentration. म्हणजे हे अँटीबायोटिक आपण अगदी थोड्या प्रमाणात जरी वापरत असलो तरी सुद्धा ते एका मायक्रो ऑर्गॅनिझम पासून मिळालेले केमिकल सबस्टन्सेस जे आहेत ते दुसऱ्या मायक्रो ऑर्गॅनिझमला किल करतात किंवा त्याची ग्रोथ थांबवतात. तर आपण जर इव्होल्युशन अँटीबायोटिकचं बघितलं तर अँटीबायोटिक कसं डेव्हलप होत गेलं, तर सुरुवातीच्या काळामध्ये जसं पॉल एल्ड्रिच इन 1907 त्यांनी एक नाव दिलं त्याला, दॅट इज कॉल्ड मॅजिक बुलेट. इट वॉज नॉट अँटीबायोटिक ॲट दॅट टाइम अँड द पॉल एल्ड्रिच सेड दॅट देर इज द ड्रग विच इज टार्गेटिंग स्पेसिफिकली समथिंग. म्हणजे ते अशा एका गोष्टीला टार्गेट करताय. फॉर एक्झाम्पल इट इज टार्गेटिंग ओनली द मायक्रो ऑर्गॅनिझम आणि ती होस्टला अफेक्ट करत नाहीये, म्हणजे पेशंटला त्याचा कुठलाही त्रास होत नाहीये, ते स्पेसिफिकली फक्त microorganisms target करते हैं and he has given name to it, that is a magic bullet. So in 1942 the Selman Waxman, he coined the term antibiotic. Before 1942, actually there was a discovery of antibiotic, and the name given to the antibiotic in 1940 was the in 1928 it was the antibacterial agent, and this is the very phenomenon discovery which was done by the Fleming, Alexander Fleming, in 1928 has discovered the antibiotic and त्यांनी त्याला नाव दिलं antibacterial agent. And it was an accidental discovery. तुम्हाला ही सगळी स्टोरी माहित असेल की how the penicillium notatum and the streptomyces where the growth of streptomyces has been inhibited by the penicillium notatum, and accidentally Alexander Fleming has found this. त्यांना हे सर्व मिळालं, but it will take another 12 years. याला पूर्ण 12 वर्ष जावी लागली पेनिसिलिन actual commercial production व्हायला. आणि during the 1940, during the World War II, the Florey and Chain, they have commercially produced the penicillin, and in 1942 the Alexander Fleming along with the Florey and Chain, they have received the Nobel Prize for this penicillin discovery in 1945. So later on, it was keep evolving these antibiotics. Later on, in 1950s, 60s, it is having various antibiotics like tetracycline, macrolides. All these are the broad spectrum antibiotics. Then the new synthetic classes are arrived. In 1920, 2000, modern antibiotics are arrived. Now in 2010-20, it is continued with the reuse of the drugs or the stewardship program, that we will see what it is, revival and the stewardship. Okay, so considering the origin of the antibiotic, either they are the natural antibiotic, a natural है if we are getting it from the microorganism. We are calling them as a semi-synthetic. For example, if we are getting the antibiotic from the natural origin and we are making some modification in the laboratory. जर आपण laboratory मध्ये काही modification करत असलो, for example, we are getting penicillin and we are modifying, so we are making ampicillin, proxacillin likewise, cephalosporin likewise. And in case of the synthetic, when we say synthetic completely, so they are discovered in the laboratory and they are completely synthetic. ते पूर्णपणे synthetic आहेत आणि ते lab मध्ये बनवलेले आहेत. For example, different sulfa drugs, fluoroquinolones, sazolidinediones. All these are the synthetic antibiotics. Okay, depending on again their mechanism and their spectrum of activity, they are classified. For example, the antibiotic which is specifically targeting a single microorganism, then what we call it as a narrow spectrum. And the antibiotic that is effective against various microorganisms, what we call it as a broad spectrum antibiotics. So what is the major limiting step? Major limiting step जो एक मोठा अडथळा आपण त्याला म्हणू शकतो की अँटीबायोटिकच्या डेव्हलपमेंटमध्ये आहे, किंवा आपल्याला सतत नवनवीन नेक्स्ट जनरेशनचे अँटीबायोटिक्स हे बनवत राहावे लागतात. त्याचं रिझन हे आहे की these microorganisms, they are developing the resistance to the antibiotic and they are having different mechanisms. The microorganisms, they are developing the mechanism in a such a way that they are modifying themselves by using one or the other mechanism, आणि त्या मेकॅनिझमचा वापर करून ते त्या पर्टिक्युलर अँटीबायोटिकला रेजिस्टन्स डेव्हलप करतात, जेणेकरून त्या अँटीबायोटिकचा मायक्रो ऑर्गॅनिझमवर कुठलाही परिणाम होत नाही. सो कशा पद्धतीने ते मेकॅनिझम कसं काम करतं, कसं ते रेजिस्टन्स डेव्हलप करतात मायक्रो ऑर्गॅनिझम, तर त्याचे वेगवेगळे मार्ग आहेत. फॉर एक्झाम्पल, जेनेटिक म्युटेशन, त्यांच्या जनिकीय संरचनेमध्ये बदल होतो आणि ते म्युटेशन होतं, आणि ते झाल्यामुळे जे काही अँटीबायोटिक आपण यूज करणार आहोत, they are not able to bind at the particular site due to the genetic modification. किंवा एन्झाईम डिग्रेडेशन, आपल्या सर्वांना माहित आहे की penicillin is an enzyme which is acting or destroying the penicillin. Beta lactamase which is destroying the beta lactamase. So these microorganisms, they are secreting certain enzymes, की असे एन्झाईम सिक्रेट करतात की ज्याने जे काही अँटीबायोटिक असतात ते डिग्रेड होतात. किंवा इफ्लक्स पंप, मायक्रो ऑर्गॅनिझम दे आर डेव्हलपिंग द इफ्लक्स पंप. सो हे अशा प्रकारचे पंप्स असतात, ते मायक्रोबच्या सेल वॉलमध्ये असतात. जे काही अँटीबायोटिक त्या मायक्रो ऑर्गॅनिझमच्या आतमध्ये जातात, ते इफ्लक्स पंप त्यांना पुन्हा बाहेर काढतात. जस्ट लाईक अ मोटर, जे कसं जे पाण्याला बाहेर फेकते विहिरीतून, तसं हे इफ्लक्स So there are certain channels like purine channels present in the gram negative microorganism, which is allowing the decreasing. So binding protein ह्या specific प्रोटीनलाच बाइंड होता and then it will be affecting the cell wall synthesis. But what is happening here, इथे काय होत आहे की जे पेनिसिलिन बाइंडिंग प्रोटीन आहे त्याचं जे स्ट्रक्चर आहे ते चेंज होत आहे and that's why the penicillin is not able to bind. ते तिथे बाइंड होऊ शकत नाही. फॉर एक्झाम्पल द मेथिसिलिन रेजिस्टन्स स्टेफिलोकोकस अल्टर्ड penicillin binding protein. So it is a kind of microorganism which is having an resistance to the methicillin. Next one, it is a horizontal gene transfer. So just like a genetic mutation here क्या होता है? There are certain reasons. For example, excess heat, excess radiation, lack of food. So in case of horizontal gene transfer, what is happening here? Also a genetic modification may occur, and which is due to the transfer of the plasmid. Now plasmid is what? A circular DNA, and this circular DNA which is having the R factor, and that R factor हा याच्यासाठी रेजिस्टन्स साठी रिस्पॉन्सिबल असतो आणि तो एका मायक्रो ऑर्गॅनिझम पासून दुसरीकडे ट्रान्सफर होतो आणि त्याच्यामुळे दुसऱ्या मायक्रो ऑर्गॅनिझम मध्ये सुद्धा रेजिस्टन्स हा डेव्हलप होतो पर्टिक्युलर अँटीबायोटिकच्या अगेन्स्ट. सो दीज आर द डिफरंट मेकॅनिझम थ्रू विच द मायक्रो ऑर्गॅनिझम नाव डेव्हलपिंग द रेजिस्टन्स. तर द कॉजेस, ही कुठली कारणं आहेत की ज्याच्यामुळे अँटीबायोटिकला रेजिस्टन्स हा डेव्हलप होत असतो. So if we consider the human factors, so there is always overuse, misuse or underuse. एक तर अँटीबायोटिकचा अतिरेक, त्याचा कमी वापर, ओके, किंवा सेल्फ मेडिकेशन, या सगळ्या प्रकारामुळे अँटीबायोटिकला रेजिस्टन्स हा डेव्हलप होत असतो. इनकम्प्लीट ट्रीटमेंट, यूज ऑफ ब्रॉड स्पेक्ट्रम अँटीबायोटिक्स अननेसेसरीली, म्हणजे जिथे फक्त तुम्हाला नॅरो स्पेक्ट्रम एक स्पेसिफिक मायक्रो ऑर्गॅनिझमच्या अगेन्स्ट तुम्हाला फॉर एक्झाम्पल अमॉक्सिसिलिन यूज करायचंय तर तिथे तुम्ही टेट्रासायक्लिन यूज करताय. सो अल्टिमेटली द मायक्रो ऑर्गॅनिझम डेव्हलपिंग द रेजिस्टन्स टू द टेट्रासायक्लिन. नेक्स्ट वन, इट इज अन हेल्थ केअर सिस्टम फॅक्टर्स लाईक फॉर एक्झाम्पल पूअर इन्फेक्शन कंट्रोल इन हॉस्पिटल. पेशंट एका डिसीजसाठी हॉस्पिटलमध्ये तो ॲडमिशन त्याचं होत असतं आणि त्याच वेळेला असं होतं की त्याचं ट्रीटमेंट एका डिसीजसाठी सुरू आहे आणि त्याला दुसरा पण आजार होतो, व्हॉट वी कॉल इट ॲज अ हॉस्पिटल ॲक्वायर्ड इन्फेक्शन. ओके, सो द पेशंट इज हॅव्हिंग ट्रीटमेंट ओनली फॉर वन डिसीज, but at the same time he is having the another disease and for which the another microorganisms present there, they are also exposing to the previous treatment and they will be developing the resistance. Now next reason is lack of rapid diagnostic tools. आता असं होतं की कधी कधी आजार हा कुठल्या स्पेसिफिक मायक्रो ऑर्गॅनिझममुळे झाला आहे हे डिटेक्ट करण्यासाठी खूप सारा वेळ मध्ये जातो आणि तो वेळ गेल्यामुळे त्या मायक्रो ऑर्गॅनिझम अँटीबायोटिकला रेजिस्टन्स डेव्हलप करू शकतो. याचं रिझन हे आहे की पेशंट ॲडमिट झाल्यानंतर मे बी फिजिशियन्स विल बी गिव्हिंग द ड्रग्स, ते देत असतात मेडिसिन डिपेंडिंग ऑन देअर एक्सपिरियन्स, व्हॉट वी कॉल इट ॲज एम्पिरिकल थेरपी. Inadequate stewardship programs. Hospital is lacking in something. They are not having the specific motivating programs for the patient or observing the drug, not having in place a certain programs which is taking follow-up of all the treatments, especially the antibiotics. Next factor, that is agricultural and environmental factors. So antibiotic used in livestock feed for growth and promotion. आपल्या सर्वांना माहित असेल की प्राण्यांची ग्रोथ होण्यासाठी किंवा तुम्हाला हे माहित असेल की हनी बीजच्या हनी जे आपल्याला हनी मिळतं मध त्याच्यामध्ये खूप सारे अँटीबायोटिक मिळतात. ते मे बी यूज केले जातात फॉर ट्रीटिंग द व्हेरियस डिसीजेस इन द हनी बीज. फॉर एक्झाम्पल टेट्रासायक्लिन, ऑक्सिटेट्रासायक्लिन हे त्यामध्ये हनीमध्ये आपल्याला मिळू शकतं मोठ्या प्रमाणात. आणि ग्रोथसाठी जे वापरले जातात फ्लोरोक्विनोलोन्स किंवा टेट्रासायक्लिन वापरले जातात ते तुम्हाला लाईफ स्टॉक्समध्ये मिळू शकतात. एन्व्हायरमेंटल कंटॅमिनेशन फ्रॉम फार्मास्युटिकल वेस्ट. आता ज्या कुठल्या फार्मास्युटिकल कंपनीज असतात त्यांचं जे वेस्ट आहे ते नॅचरल वॉटर रिसोर्सेसमध्ये ते लोक सोडत असतात आणि त्यामध्ये जर कुठले ड्रग्स असतील, त्यामध्ये वेस्ट वॉटरमध्ये कुठले मेडिसिन त्यामध्ये काही प्रमाणात जात असतील, सो अल्टिमेटली द व्हॉट एव्हर फोना अँड फ्लोरा जे आपण म्हणतो जे मायक्रो ऑर्गॅनिझम वॉटरमध्ये सॉइलमध्ये प्रेझेंट असतात, दे आर इंटरॅक्टिंग विथ दोज pharmaceuticals. So ultimately they are developing the resistance. And then again, these microbes, they will be spreading through the water and soil. They entering into the through the food chain, and they are already having the resistance to the particular drugs. So these are the reasons how the resistance is developed by the microorganism to the antibiotics. नाव इफ वी सी द ग्लोबल बर्डन, आता सध्याचा जर सिनेरिओचा आपण जर विचार केला तर हा टॉपिक अत्यंत महत्त्वाचा का आहे, तर करंट इम्पॅक्ट आपण बघितला तर इट इज 1.27 मिलियन डेथ. 1.27 मिलियन, it is equal means it is 12,70,000. 12,70,000 people, they are dying per year due to the this antimicrobial resistance. So the microbes, they are developing the resistance to the antibiotics, and because of this reason only 12,70,000 people all over the world, they are dying yearly. अँड इफ वी आर एक्स्ट्रापोलेटिंग, आपण हा जर डाटा जर भविष्यामध्ये याला आपण एक्स्ट्रापोलेट केला तर 2050 मध्ये ही परिस्थिती अशी असेल की 10 मिलियन पीपल्स विल डाय. म्हणजे साधारणतः 1 करोड लोक हे 2050 मध्ये अँटीमायक्रोबियल रेजिस्टन्समुळे त्यांची डेथ होऊ शकते. सो हिअर कम्स द रोल ऑफ द फार्मासिस्ट. सो इथे आपला खूप मोठा रोल आहे. सो विल सी हाऊ वी कॅन प्ले अवर रोल टू अवॉइड दिस ट्रॅजेडी इन द फ्युचर. सो व्हॉट इज द अवेअर क्लासिफिकेशन. आता आपल्याला जे अवेअर क्लासिफिकेशन जे आहे, जे आपल्याला फॉलो करायचे, जे आपल्याला WHO ने दिलं आहे, ते आपल्याला कशा पद्धतीने फॉलो करायचं, आपण त्याचा थेरॉटिकल पार्ट बघूया. So in 2017, WHO reviewed the 21 common infections. So there are certain common infections only, and WHO has studied all those 21 infections, and considering the all the characteristics of the infection, WHO ने काय केलं की त्यांनी असे सुटेबल अँटीबायोटिक्स सिलेक्ट केले, कन्सिडरिंग द बेनिफिट, हार्म्स अँड रेजिस्टन्स पोटेन्शियल ऑफ द अँटीबायोटिक. म्हणजे जो काही अँटीबायोटिक्स पासून होणारा फायदा, तोटा आणि रेजिस्टन्स किती डेव्हलप होऊ शकतो ऑप्टिमम, असं अगेन्स्ट दॅट पर्टिक्युलर 21 डिसीजेस त्यांनी काही ड्रग्स सिलेक्ट केले. सो इसेन्शियल अँटीबायोटिक्स वेअर ऑर्गनाइज्ड, आणि त्यांनी त्याला 3 कॅटेगरीमध्ये डिवाइड केलंय. द फर्स्ट वन ॲक्सिस, सेकंड वन दॅट इज वॉच, थर्ड वन त्याला आपण म्हणतो रिझन. आता इन 2029 मध्ये क्लासिफिकेशन एक्सपांडेड ग्लोबली अँड नाऊ अपडेटेड बाय WHO एव्हरी 2 years. सो 2019 मध्ये त्यांनी हे क्लासिफिकेशन ग्लोबली त्याला अपडेट केले, आणि दर 2 वर्षाला आता ते अपडेट करतात. WHO पब्लिश्ड अँड अवेअर अँटीबायोटिक बुक डिटेलिंग हाऊ टू यूज द अँटीबायोटिक्स फॉर कॉमन. त्यांनी पूर्ण डिटेलमध्ये ह्या WHOच्या बुकमध्ये माहिती दिलेली आहे. आपण याला समरीमध्ये स्टडी करणार आहोत. So what is the access group? So when we say the access groups of the antibiotics, so these antibiotics generally they are narrow spectrum. म्हणजे ते एका स्पेसिफिक पर्टिक्युलर मायक्रो ऑर्गॅनिझमच्या अगेन्स्ट मध्ये इफेक्टिव्ह असतात, अँड दॅट्स वाय वी कॉल इट नॅरो स्पेक्ट्रम. कॉमन बॅक्टेरिया, लोअर रेजिस्टन्स, अँड त्याला रेजिस्टन्स डेव्हलप होण्याचे चान्सेस खूप कमी असतात. इसेन्शियल फर्स्ट और सेकंड चॉईस फॉर मेनी इन्फेक्शन. आणि हे जे काही आहेत अमॉक्सिसिलिन, एम्पिसिलिन, दीज आर the first line drugs, and which is there are very less chances of development of resistance to these antibiotics, and they are having very low toxicity also. Means what? They are having very high safety profile, mostly used in the primary care settings. So in case of the primary diseases, okay, non-severe diseases, where we can utilize these access group medicines, antibiotics. Second group, that is an watch group. So watch group, obviously these are the broad spectrum antibiotics. Since they are broad spectrum, the chances of the development of resistance also higher. म्हणजे जर आपण एक अँटीबायोटिक जे खूप साऱ्या मायक्रो ऑर्गॅनिझमच्या अगेन्स्टमध्ये जर काम करत असेल तर त्याला रेजिस्टन्स डेव्हलपमेंट होण्याचे चान्सेस पण तेवढे जास्तच असणार. सो की टार्गेट ऑफ स्टीवॉर्डशिप प्रोग्राम. सो वी हॅव टू कन्सिडर दिस watch group antibiotic for the stewardship program. Stewardship, it means we have to use the antibiotics critically and cautiously. That's what we call it as a stewardship. Limited use only when access group is not effective. So we are utilizing this watch group when the access groups they are found ineffective. This obviously, these watch groups, they are having the higher toxicity, and they are mostly used in the hospitals and given by the injections. So these are the watch groups. Next one, that is an reserve group. So these are रिझर्व, द नेम इटसेल्फ इंडिकेट, आणि हे आपण एका पर्टिक्युलर केसमध्ये, एखाद्या पेशंटच्या पर्टिक्युलर केसमध्ये सिरियस सिच्युएशन आणि रेजिस्टंट इन्फेक्शन्स जर असेल, की ज्या इन्फेक्शनला इवन वॉच ग्रुप सुद्धा ट्रीट करू शकत नाहीये, त्या स्पेसिफिक केसमध्येच आपण रिझर्व ग्रुप अँटीबायोटिक यूज करत असतो. Closely monitored as a high priority to prevent the resistance. So we have to monitor this administration of these drugs very closely, because the chances of development of resistance are very high. कारण यामध्ये रेजिस्टन्स डेव्हलप होण्याचे चान्सेस खूप जास्त असतात. Strictly limited to specific patient and settings, used for multi-drug resistance bacteria. So we can utilize this reserve group if there is a development of multi-drug resistance bacteria, like we have saw that multi-drug resistance staphylococcus aureus. So this is the classification. So as per the AWaRe classification, 251 antibiotics on 2023 AWaRe list, out of which 41 antibiotics are on the essential medicine list. So the WHO, that is publishing the essential medicine list, and these in this essential medicine list there are 41 antibiotics, and these 41 antibiotics we have categorized. WHO has categorized it as either access group, watch group, or the reserve group antibiotics. So we have already saw what access group is, what is the meaning of watch group, and what is a reserve group. One more category additionally they have added, and it is 103 antibiotics, and what it is called as not recommended groups. So along with the access group, watch group, and reserve group, there is one more category, and what we called it as not recommended. Means these antibiotics, they might be available in the market, that is synthesized by the companies, but the what WHO has found that no, not any of the single quality organization, असे जगातले कुठलेही क्वालिटी ऑर्गनायझेशनने अशा कुठल्याही गाईडलाईनच्या अंडर ह्या अँटीबायोटिकची इफिशियन्सी कुठेही सिद्ध झाल्याचं सांगितलेलं नाही. Because these groups include antibiotics whose use is not supported by evidence. There is no any such proof that these antibiotics are effective. These groups include mainly fixed dose combination of multiple antibiotics. आता याच्यामध्ये काय आहे की unnecessary there is a combination of 2-3 more antibiotics which is of no use. आपल्यालाही माहित असेल की FDA ने आपल्याकडे खूप सारे फिक्स्ड डोस कॉम्बिनेशन जे आहे की ज्यांचा काही उपयोग नाहीये ते कधीच बंद केले. These antibiotics are not included on the WHO model list of essential medicine, and their use in clinical practice is not recommended. हे कुठेही WHOच्या मेडिसिन लिस्टमध्ये यांचा उल्लेख नाहीये, आणि याचा कुठलाही क्लिनिकल प्रॅक्टिसचा यूज WHO रिकमेंड करत नाही, आणि आपण त्यांना म्हणतो नॉट रिकमेंडेड ग्रुप. So we'll see which drugs that is coming under the access group, watch group, and reserve. Quickly go through it. Access group that include the amikacin, amoxicillin, amoxicillin, clavulanic acid, benzathine, benzyl penicillin alone, cephalexin, spazolin, chloramphenicol, clindamycin, clobacillin, doxycycline, flucloxacillin, gentamicin, metronidazole, nitrofurantoin, phenoxymethylpenicillin, propanbenzyl penicillins, then spectinomycin, sulfamethoxazole, and trimethoprim. This is coming under the access group. Watch group having the 12 candidates, it include azithromycin, cefixime. So you can see how frequently the physicians, they are prescribing this drug, azithromycin, we all know, cefixime, then cefotaxime, ceftazidime, ceftriaxone, cefuroxime, ciprofloxacin, clarithromycin, imipenem, then cilastatin, meropenem, piperacillin, tazobactam, and vancomycin. While the reserve group that includes 9 drugs that include the cefiderocol, then the ceftazidime, avibactam, ceftolozane, azobactam, then colistin by intravenous route, fosfomycin intravenous, linezolid, then meropenem, and vaborobactam, plazomycin, and the polymyxin B. So these are the candidates from the reserve. Now we are moving to the application of the theoretical part that we have learned in this AWaRe classification in our practice during the dispensing. So we can see that the around 50% of diseases, they don't need an antibiotic. Antibiotics are not needed for this. The flu, cold may not be requiring the antibiotics. Like bronchitis, pharyngitis, these are what the inflammation. There we need what the anti-allergic agents, anti-inflammatory agents that we need to give. Also, the 50% diseases they don't need the antibiotics. 90% of antibiotics used in the primary care, 50% are inappropriate. So whenever we are utilizing the 90% antibiotics in primary care, the 50% that is of no use. WHO's target is to increase the consumption of the excess group more than 60%. So WHO ने काय target ठेवलंय की to utilize the excess group antibiotics and which is beyond 60%. So instead of directly going to the watch group or reserve group, we have to more utilize the excess group antibiotics. So how the pharmacist can implement this? So starting from coming the prescription to the pharmacist. So जर फार्मासिस्टकडे कुठलेही प्रिस्क्रिप्शन येणार असेल किंवा प्रिस्क्रिप्शन येणार नसेल, त्याच्याकडे प्रिस्क्रिप्शन आलं आणि त्यामध्ये जे आपण ड्रग बघितले 20 लिस्ट जी आहे 20 अँटीबायोटिकची लिस्ट जी आहे ॲक्सेस ग्रुपमधली ती असेल तर आपण तो ड्रग आपण डिस्पेन्स करू शकतो पेशंटला आणि आपण त्याला instruction proper द्यायचे आहे related to what correct dose and clear instruction when to administer, how to administer before meal, after meal, all the instruction that we have to give. So the role of the pharmacist is done here. But if the drug that is given in the prescription जे दिले आहे ते ऍक्सेस ग्रुपमध्ये नसतील, ते वॉच ग्रुपचे असतील किंवा प्रिस्क्रिप्शनच तुमच्याकडे आलं नसेल तर त्या केसमध्ये काय करायचं? सो इफ in case of watch group, we have saw that the risk will be very high. Okay, and there are chances that the microbes will be developing the resistance to the antibiotics. Okay, so here the pharmacist need to evaluate the patient and assess the need, confirm that the patient require these watch group antibiotics, and educate the patient accordingly. And in case the last group, if the pharmacist need to डिस्पेन्स जर फार्मासिस्टला रिझर्व ग्रुप अँटीबायोटिक डिस्पेन्स करण्याची वेळ आली तर त्या केसमध्ये फार्मासिस्ट मस्ट हॅव टू कन्सल्ट द स्पेशलिस्ट अँड रिस्ट्रिक्ट द यूज, लिमिटेड यूज शुड बी देअर आणि वी हॅव टू क्लोजली मॉनिटर द पेशंट. So the same has been given here. The process begins with the patient prescription and pharmacist checks whether the prescription is appropriate or not. And also in case of access group, we simply dispenses the drug. Correct dose and clear instruction will be given. These are low resistance risk drug recommended for common infection. So in case of watch group, so pharmacist role is major role of the pharmacist, evaluate the necessity and whether it is truly required or not, that pharmacist need to identify. हे pharmacistला बघितलं पाहिजे. Provide the patient education about the risk and the adherence. So it is one of the important factor, adherence or the patient compliance. जे काही थेरपी ट्रीटमेंट किंवा रेजिम आपण पेशंटला देत असतो ते पेशंटले तंतोतंत फॉलो केलं पाहिजे. फॉर एक्झाम्पल इफ इट इज फॉर 3 days, 5 days, 7 days and whatever, twice daily, thrice daily, so patient, so pharmacist must have to ensure that की त्यांना ते डोस आणि जी काही फ्रिक्वेन्सी आहे त्या पद्धतीने ते पेशंट ऍडमिनिस्टर करताय की नाही. These drugs carry higher risk of resistance and should be used cautiously. So as we have saw, watch drugs, there are chances of development of the resistance are very high. Now, if the drug that is belong to the reserve group, use only critically needed. If it is the case where the access and the watch groups they are found ineffective, and pharmacy should consult the specialist in that case and restrict use and monitor closely these after the administration to the patient. And these are last resort drugs reserved for multi-drug resistant infection. If the patient has developed multi-drug resistance, so we can utilize these last resort drugs for the multi-drug resistant cases. So there are some examples. We can see that where these antibiotics may not be needed. For example, common infections and antibiotic choices. In case of bronchitis, there is no need of antibiotic. We may need a certain anti-inflammatory agent, anti-asthmatic agent. We may need certain leukotriene inhibitors, lipoxygenase inhibitors, anti-allergic drugs, steroids that may be required as per the inflammation that is present in the bronchi and not the antibiotic. Otitis media, we can use amoxicillin. It is an accumulation of the fluid in the middle ear drum. Strep throat, here we can utilize the scratchy throat. If it is there, then in that case we can use penicillin. Sinusitis, it is an inflammation of the sinus linings where we can give the treatment as per the symptoms. For example, this sinusitis may occur. हा सायनुसायटिस बॅक्टेरिया व्हायरस किंवा ॲलर्जी कशामुळे होऊ शकतो. सो तो कशामुळे झालाय डिपेंडिंग ऑन दॅट सिम्पटम वी कॅन यूज अँटीबायोटिक. अँड डेंटल इन्फेक्शन्स, सो इन सिव्हिअर केसेस वी कॅन यूज द अँटीबायोटिक इन केस ऑफ द this severe infection. Amoxicillin we can. So we'll see an example of the case studies. For example, if the patient coming with an urinary tract infection of 25-year-old female showing the symptoms of burning urination, frequent urination, mild lower abdominal pain, no fever, no flank pain, and suggests the uncomplicated urinary tract infection. असं जर त्या पेशंट कडून असं सांगण्यात आलं तर in that case likely cause most common organism is the E. coli. So depending on that empirical therapy, we can identify that the causative agent may be the E. coli. And considering the AWaRe principle and empirical treatment, according to the AWaRe classification, we can start with the access group antibiotics. So here we can give the nitrofurantine. Nitrofurantine can be given as an access group antibiotic to such the female that is suffering from this UTI infection. So here it is why we are selecting nitrofurantine, because this nitrofurantine, it is an narrow spectrum antibiotic having low resistance potential, high concentration which is present in the urine, and low amount present in the gut flora. And dose and duration of nitrofurantine is 100 milligram twice daily for 5 days. Now, what is the scenario if the UTI doesn't get treated? So in that case, follow the stewardship principle, use short course therapy. Stewardship principle, what it is saying that we have to use the drugs very cautiously. Okay, so here what we can do, we can utilize the another broad spectrum antibiotic, but we have to avoid the unnecessary use of the broad spectrum antibiotic, and no antibiotic change if the patient improves. If there is any kind of improvement in the patient, we are not going to change the antibiotic. Third step, when to escalate to watch group. Now we have treated the patient for 5 days, and at the middle of, like at the 48 and 72 hours, at the between 2 and 3 days. So the culture that we have developed from the urine sample of the patient showing that the presence of resistant organism, आपल्याला असं आढळून आलं 2 ते 3 दिवसामध्ये की पेशंटमध्ये इम्प्रूव्हमेंटही होत नाहीये, आणि जे कल्चर डेव्हलप केलंय त्याच्यामध्ये असे मायक्रो ऑर्गॅनिझमची ग्रोथ होते जो रेजिस्टंट आहे. Then consider watch group antibiotic in that case like ciprofloxacin, cefixime, and because we are selecting it because this is the broad spectrum antibiotic, and it is obviously having the high risk. Now step 4, it is a severe complicated UTI reserve group. Now even after utilizing the watch group antibiotic like ciprofloxacin, cefixime, the UTI still not get treated, so we have to shift to the severe reserve group. If patient develop fever, sepsis, hospital acquired infection, multi-drug resistance, organism detected, use the reserve group antibiotic like we can use the colistin, ceftazidime, avibactam. The reason is last resort drug for resistant infections. So this is the flow that the pharmacists must have to follow. For example, first we are utilizing empirical therapy, then we are utilizing access drug, then we are utilizing the stewardship principle, then we are utilizing the watch drugs, and still if it is not improved, then we can utilize the reserve. So this is the example of UTI. Now you can see that how we can use this AWaRe in the dispensing. So we must have to give the detailed information to the patient like right drug and match to the infection. We have to make sure that we are giving the drug to which is having the particular use in a specific disease. For example, if we are giving the drug amoxicillin that is effective in tonsillitis, right dose and correct strain. Like here we are giving the 500 milligram amoxicillin, and the patient must have to administer it thrice a day frequency. Right duration, so the patient must have to complete the therapy for the 5 days, and right indication, whether it is for the bacterial, viral, or the allergic, for what kind of the indication we are giving this drug. So the duration that may be vary, whether it may be given for 3, 5, or 7 days, depending on the requirement. Like it may be a fast recovery, optimal outcomes are required, or the over treating. We have initially only saw the underuse, overuse of this or misuse of the antibiotics may result into development of resistance. Now the next part, it is on patient counseling. So it plays very important role, especially when we are giving the, the second class. Okay, so the watch drugs. Whenever we are giving the watch drugs, in that case, the patient counseling plays important role. So the pharmacist must have to explain what is antimicrobial resistance in a brief or in the understandable language to the patient, and we have to tell them how the bacteria they are learning, how they are developing resistance through different mechanisms. Stress adherence, as we have discussed, stress to the adherence. So here the compliance, patient compliance or adherence to the therapy, like we have saw in case of the tonsillitis, we are giving amoxicillin 500 thrice a day. So the patient must have to take it thrice a day and for a 5 days full treatment. So the adherence must be there. Patient compliance is the plays the major role in the success of any kind of the therapy. Correct the myths. So we must have to make aware the patients regarding the some myths like antibiotic. They are not for the colds. Okay, so we are not utilizing it for the colds. Return unused medicines. So patient would may like to give the some medicines return. They may be unused. So then only we are able to track. So as a pharmacist, we have to develop certain kinds of the policies. Then we can track whether the patients have administered the drugs, what is the reason, and ultimately we can find that if they are not taking this medicine, there are chances of the development of the resistance in those patients. So we can counseling them time to time when they come for returning the medicine. So there is one more additional point that is called as the stewardship and the revival. So stewardship, what it indicates. So stewardship, it means we have to rationally and responsibly use the available antibiotics for the current generation. Okay, so to avoid the unnecessary prescription, shorter treatment course, narrow spectrum, we have to give the preference, hospital stewardship programs we have to run. Okay, so by doing this, we are utilizing the present antibiotics for the current generation, and ultimately we are not allowing to suffer our upcoming generation through the resistance. So that is the stewardship. And revival, revival, it indicates that the drugs or therapies or different kinds of the diagnostics, they are already died or they are not available, or these drugs they have already developed the resistance. So we need to develop the new diagnostic methods. We have to identify new therapies. We have to identify new diagnostic, new vaccines. Likewise, that is what we call it as a revival. So in revival, develop the new solution, creation of new drugs, diagnostics and treatments, new antibiotics. We can use new combination drugs, rapid diagnostic, and alternative therapies like the vaccines. So this stewardship and the revival program also plays important role in avoiding the development of the resistance. So in conclusion, what we have learned in today's seminar that includes the and pharmacists must have to consider these following points, which includes to understand the antimicrobial resistance burden, to learn and be aware categories that we have saw, that is access, watch, and reserve groups and their importance. Apply this theoretical knowledge in dispensing the drugs during the day-to-day practice. And to improve the patient counseling, educate the patient on appropriate antibiotic use and tell them about the importance of the patient compliance or the adherence. And the last one, that is an implementing the stewardship and the revival. So cautiously using the antibiotic in the present scenario and develop the new antibiotics and diagnostics and treatment for in the upcoming days. So this is the website link that is available here. You can go directly or you can scan this code and you can find all these antibiotics. They are categorized either as the access group, watch group, reserve group, as mentioned in our seminar. So these are some of the references. Thank you very much. I'm just showing you the that link. So you can directly go to this link either by clicking it or by simply scanning it, and you can see here. This is an triacetyl spiramycin plus metronidazole. Okay, so this is the not recommended. N that indicates not recommended. So green one, A that indicates the access group. So amikacin, which is given here. So all these antibiotics, they are mentioned here along with their labeling. A indicates the access group, N indicates the not required. So likewise, all these like arabic acid, that is an watch group. Okay. So likewise, all these antibiotics by the WHO has categorized the here, so we can simply access this here. So thank you very much. That's it from my side. Over to you, madam.
Thank you so much for addressing the participants, sir. I'm sure that whatever information you gave them might have felt really valuable. And the hands-on website which you showed them the interface, I'm sure that all the participants will try to. So thank you once again for giving us your valuable time. Also, to all the participants, I'd like to inform that the Drug Information Center of Maharashtra State Pharmacy Council has already released a publication on AWaRe classification and antimicrobial stewardship, especially for pharmacists. And the link for the publication has been given in the description below. All you guys can check it out, download and read the material, and refer to it when you are dispensing, and also following the tips sir gave you for the counseling today, so that we are more aware and cautious towards judicially using the antibiotics, which are available for us currently to treating the patients. Thank you, everyone.
Thank you.